Greetings of the day, folks. Today we are going to discuss about how to diagnose a case of DKA. DKA, so we know that diabetic ketoacidosis, right? So diabetic means first initial phase should be must be hyperglycemia. So the cutoff value is 250 milligrams per deciliter or 13.9 millimoles per liter. And ketoacidosis, acidosis, right? So as ketones produce acidosis. So acidosis causes anionic gap. So it is HAGMA, that is and high anionic gap metabolic acidosis. So the anionic gap will be more than 10 to 12. That is the cutoff to diagnose the DKA. And bicarbonate level, because of the acidosis, will reduce to low values, and the cutoff value is 15 millimoles per liter, and a pH of less than 7.3 with moderate ketonuria or ketonemia constitutes the diagnosis of DKA. So normally, traditionally, DKA is divided into mild, moderate, and severe. Mild cases will have an arterial pH of 7.25 to 7.3, then serum bicarb of 15 to 18, and anionic gap of more than 10. When coming to moderate DKA, the arterial pH will be 7.0 to 7.24, serum bicarbonate of 10 to 15, and anionic gap of more than 12. And patient might be drowsy to alert. Okay, here there is a mental status, altered mental status to some extent. Okay, and in case of severe DKA, the pH will be less than 7.0, bicarb of 10, less than or less than 10, and anionic gap of more than 12. And patient will be stuporous to comatose. In some patients, we'll see euglycemic DKA. So normally, hyperglycemia is a requirement for diagnosis, but in some patients, the risk patients will seeing the patients in which we see euglycemic DKA are in patients present shortly after receiving insulin, type 1 diabetics who are young and vomiting, and patients with impaired gluconeogenesis, that is alcohol abuse or liver failure, low caloric or intake or starvation, depression, pregnancy, and SGLT2 inhibitors, that is dapagliflozin and canagliflozin, empagliflozin. So these causes euglycemic decay. The mechanism why the SGLT2 inhibitors cause the euglycemic decay due to there is increased glucose secretion in the urine, thereby decreasing carbohydrate availability. So because of this, there is subsequent drop in the insulin release and it inhibits the gluconeogenesis. Okay, and also there is a decreased requirement of insulin in patients who are using SGLT2 inhibitors. So in euglycemic decay, the glucose will be less than 250 milligrams per deciliter, and it can create a diagnostic challenge. Okay, so we must be careful in the discussed patients, because patient might be having DKA and we won't suspect DKA and we won't treat in those terms. So we must be careful in these patient population. And also, so clinical suspicion of ketosis should be suspected in patients with ketosis who presents with nausea, vomiting, malaise in this unique subset. Okay, and beta hydroxybutyrate value generally will be more than 3 milliequivalents or 3 millimoles, and that can aid in prompt diagnosis. So, and treatment includes dextrose containing fluids coupled with insulin therapy until ketosis resolves. Thank you very much.